Probably one. I think we are now live on YouTube. Okay, so let's see. I'm just going to wait 1 minute and then we'll start. Probably one. Okay. So welcome to Essence of Medicine podcast. And today uh, we won't have Amanda for you, but we have a special guest, Dr. Neda Gilmartin. Dr. Gilmartin, first of all, introduce yourself for our audience, and then we can talk about our podcast. Please go ahead.
All right. Well, thank you, Dr. Abbasi, for the opportunity to be present during this podcast and part of the team. I am a Belgian-trained orthopedic surgeon who is now going to be part of the team of Inspired Spine after 3 spine fellowships. And I'm more than excited to be here and see where this podcast is going to lead us. So,
Now, number one, let's talk about, obviously you are an orthopedic spine surgeon, correct?
correct, sir.
And I guess that really qualifies you to talk about the spine and all spine-related issues. Now, tell me, when did you do your residency?
My residency is a while ago. I did my residency in Belgium.
The orthopedic surgery, in the orthopedic.
It was orthopedic residency, mid 2000s, 2005, and I finished in 2010.
2010. Now, during your residency, did you get exposure to spinal fusions?
Not much. So, and again, the training was a little bit different, the US training and European training. You can, in a way, if you have interest in other part of the body, you can actually have more freedom to pick and choose. And so, unfortunately, my exposure to spine was not as abundant as I wished it to be.
Yeah. So, but then eventually you got a fellowship in Belgium, correct?
The fellowship in Belgium, my initial interest, and do not judge me for that, Dr. Abbasi. I was in joint fellowship and hip and knee joints. And so my initial conversion to spine was my first fellowship in Louisville, Kentucky, under the leadership of Dr. Glassman and so forth. And it was a great leadership, which kind of reawakens my passion for spine.
And so tell me about the different kind of spinal fusion you were exposed to in your fellowship.
And I had the fortune to have been exposed to multiple sort of spine fusion surgeries, and so I have seen the classic. And how I was initially exposed was the posterolateral fusions.
Mhm.
And again, but
Tell
that
us
is
a little
probably
about, let's dive into it right away, because the title of this podcast is All the Lifts You Can Have.
Oh, yes.
What does that mean?
That means that we can access the lumbar spine and the spine 360 degrees. And so
LIF stands for
lumbar interbody fusion.
Yeah, so meaning that most of the spinal fusion ends with LIF because it is a path to get to the spine, and then lumbar interbody fusion, LIF. So
Correct.
that's what LIF stands for. Now, first you talked about the posterolateral fusion. Tell us a little about the posterolateral fusion in the spine.
Well, this is the first one that I was exposed to, but then again, I wanted to maybe start with that is the classical way, the PLIF that was initially done with stripping of the muscles, exposing it extensively. We will talk about still obviously further when for the patient how invasive that must be, and traction on the nerve roots to get access to the disc space. And I think the PLIF has been making place for different approaches, which is, for instance, the TLIF, which we'll come to that as well as whenever you decide to change the and then one of the other most successful was the ALIF, which is the anterior approach to the lumbar.
Let's stick for the posterolateral fusion.
Sure.
Now,
So the posterolateral,
what does PLIF stand for?
Posterolateral interbody fusion.
Yes. So when do you think the surgeons start doing PLIF?
Well, first of all, the spine pathology starts with a disc disease, discogenic disease. And so that's where the whole cascade of the pathology starts. And with causing disc collapse, facet joint arthritis and dislocation, subluxation, and spinal canal stenosis, and the whole cascade starts. Okay, here's the beautiful image. And one of the classical ways of approach the spine is from the posterior, from the back, opening the canal, accessing the disc, retracting the nerve roots, and taking the disc out, placing a cage or whatever means of interbody that we choose to place in.
Yeah, I think this podcast is mostly for people who are not doing what you and I are doing. I don't believe we need to get into lots of technical details of it, but generally, PLIF stands for posterolateral interbody fusion or posterior interbody fusion. And we start doing PLIF in 1950s, actually, about 70 years ago or more. Now, do you know how we did this lumbar fusion before that? Because it was done not very successfully, I may add, but it was done even before that. Before we started doing posterior lumbar interbody fusion in 1950s, actually we did in 1930s, some people did anterior lumbar interbody fusion. You would go through the guts and put the organs to the side, get to the bad disc, take it out, take the bad disc out, put a piece of bone in. 9 out of 10 times that piece of bone was a piece of your hip. And that, so ALIF, which we still perform, is almost 100 years old technique, and PLIF is a 70-year-old technique. But then, obviously, when we started doing PLIF in 1950s, people stopped more or less doing ALIF. And do you want to guess, or do you know why after we started doing PLIF, people quit doing ALIF?
When they started to doing ALIF?
Yeah, well, in 1930s, some surgeon did anterior lumbar interbody fusion. They went through the front, opened up the belly, they pushed the organs to the side, accessed the spine, they did the surgery, and then they, in 1950s, after we could do posterior lumbar interbody fusion, most of people quit doing ALIFs. Do you want to guess why they would quit doing ALIF?
I believe at the top of the list, the major the risks that go along with the anterior approach.
Yeah.
Very specifically, the vascular, you're literally in the dangerous zone.
Yes, you are. Yes, you are.
And the need for an access surgeon, which is not everywhere available.
At that point, it wasn't like today that we had spine surgeon and then the access surgeon. It was a general surgeon who would learn everything. It was the same surgeon who would do that. But look at that. You have to go through all your guts. Then you have vena cava here, aorta here, major vessels, the kidneys if you're farther down, the ureter and so on. They're all in your way and so on. This used to be a high morbidity procedure. Any abdominal surgery used to be at that time a high morbidity. But at that point, very few people could imagine you can access the spine from the back through that very narrow corridor because spinal cord is here in the middle and you cannot traverse that. So in 1930s, the general surgery start improving and improving. So some surgeon probably saw by those extensive surgeries that, oh, well, here's the spine, here's the disc. Why don't we use that for actually access the spine? And they start doing that. But that would require to go through the entire abdominal cavity. And that is not a trivial task. It is much better today, but still today is a big deal to go through all the organ, prep all the vessels here. And by the way, in some of those cases that they went from the front, especially in the higher lumbar spine, patient woke up and they couldn't move their legs because some of to mobilize this vessel, aorta, sometimes you have to clip some smaller vessel coming off the aorta. And one of those vessels sometimes give blood supply to the spinal cord. And they learned the bad way. If you clip that vessel, patient wakes up and they are paralyzed. And then based on the information of the doctor who found about that vessel, we have a name for that vessel that if you clip, patient possibly will go paralyzed. Do you know what that name of that vessel is that we now call it?
Anterior
Adamkiewicz.
spinal artery.
We call it Adamkiewicz artery.
Adamkiewicz.
Adamkiewicz. Okay? So, but once they found out you can access the spine from the back, most of people more or less quit doing from the front. So, and believe it or not, for 30 years, that's all we could do. Going from the back, going to front, literally filleting you open, push the muscle to the side, then taking part of the bone off. Right here, we call this part of the bone that bridges over the spinal cord, we call that lamina. And then we go right down to the disc, where most of the time the problem is. I'm sure you have done a few of this surgery, and there's a problem with this surgery. Do you want to tell us what do you remember, or what do you think, what is the problem of PLIF? Why did we even start developing other methods?
First of all, like you said very adequately, is the stripping filleting of the muscle. Once we disinsert the muscle from the origin, the muscle will degenerate. And what do you need to have an erect, a good posture, which is the muscle? After the surgery, once the decompression is done, the nerve is free, you still need to use that back. So the muscle is the first one. Blood loss is the other one. And also, when we are actually so directly attacking and decompressing the nerve roots, we are actually having counterintuitively also the risk of nerve damage, which is one of the other.
Nerve damage is a big deal in PLIF because you're going straight down. To access the spine, you have to push the spinal cord or the nerve to the side to have a direct access to the spine, to the disc, intervertebral disc. And in the lower lumbar spine, actually, they are mostly nerve roots. They're not spinal cord in per se anymore. And you can now tolerate that. But again, we found out the based on our experience, and we found out the hard way that especially if you do it in upper lumbar spine, and God forbid you do it in the thoracic or cervical spine, try to go in and push the spinal cord to the side. It never ends up good. It just spinal cord doesn't like to be pushed around. And then based on that information, in 1980s, Dr. Jürgen Harm in Germany came up with another method. Okay, strip all the muscle, push it all to the way, but don't go straight down. Between two vertebral body, there is a structure we call facet. Why don't we take the facet off and we go at that angle? I mean at an angle that you don't have to push the spinal cord to the side. And actually, Dr. Harm got lots of crap from the spine surgeon. Say, what do you mean take the facet off? Why would we do that? That's crazy and so on. But more or less, after a good part of a decade or so, that established itself as being the so-called standard of care. Do you want to tell us what TLIF stands for?
TLIF stands for the transforaminal lumbar interbody fusion. And like you said correctly, that we do need to take the facets out. It is initially coming from the PLIF, it's like we're destabilizing the spine. Why do we have to take the facets out? But that actually, the main reason we shifted from PLIF to TLIF mainly was to avoid the traction on the nerves, which we needed to do to access the disc space. So by taking the facets out, we created a corridor, a natural corridor, and minimalizing the nerve root retraction. We just needed to create a metal wall like a nerve hook, and we had already access to the disc, and there we were. But and also the fact that we fused the spine, we realized that sacrificing the facet is not of a big deal because we fuse it.
Because we make them put something inside of where the disc used to be to make the bone grow together.
Exactly.
That something at that time was still a piece of your hip bone. By the way, after our initial experience with PLIF, when we figured out in some cases patients they have a lot of neurological deficit, ALIF had a revival. Actually, 1970s, ALIF has a revival because our abdominal surgery was much more refined and so on. And, some people even started already then to experiment with putting an artificial disc and putting other thing in. As a matter of fact, there's a nice story about John F. Kennedy, who got a surgery like that, who got an ALIF, and they put a stainless steel ball, like trying to give him an artificial disc. He almost died of it. His family started writing his obituary and so on from an infection that he had. He had Addison syndrome. So he was more prone to infection anyways, but he almost died of a surgery like that. Now, fortunately, he didn't die of that surgery, and he was a fighter, but he came very close to dying. And that brings us with the risk associated with what we, as far as now what we have talked about, PLIF, TLIF, and ALIF. So obviously, in all these surgeries, you cut, then you use electricity to stop the bleeding. Literally, you cook the tissue in place to stop the bleeding, and then you move forward. You go a little deeper, and you repeat that the same thing. Let's stay with this, with the posterolateral fusion. What did you learn in your fellowship? What are the typical complication and complication rate of posterolateral fusion?
Besides the muscle stripping,
general complication of surgeries are bleeding, infection, neurological deficit, and so on. What do you guess those complication rate be for? I would say for TLIF, because today still the vast majority of the spinal fusion are performed with transforaminal lumbar interbody fusion or with TLIF. What do you think what those rates are?
we always consent the patients and we say, yeah, those risks are minimal. And if it's a first time without patient's comorbidity, less than 1% or maybe maximum 2% if there are no comorbidities. But then again, we have the duration of the surgery that we have to take into account. And that depends between surgery and surgery.
What does that mean?
That means that obviously patients that need these type of surgeries are not the young spring chickens. So these patients are usually above 60 plus. Meaning that naturally there are comorbidities coming into effect, and the longer the surgery takes in time, besides the rest of the bleeding, muscle stripping, and so forth, anesthesia time is a big factor in patients' immediate postoperative rehabilitation and benefits. So there's the other factor that we have to take into account.
Yeah. Now, more or less is that all these surgeries, they have a risk profile of their own, and that most of the important risk of any surgery is a bleeding, infection, rate of neurological injuries, and as well failures of the surgery. These are the main complications, and each surgery has its own profile for the risk. Now, you're right. If you do it, in a selected group of people, the rate of, like infection for posterolateral TLIF group is about 1 to 2%, but generally, if you put everybody in the same bucket, it's about, in most of the literature, is recited between 3 and 5%, which is not very high, except you consider if you do a lots of it, you will have eventually, if you do 100 of it, you will have 3 to 5 patients who have a infection, and each of them can be a big deal, obviously. So far we have talked about the so-called posterolateral fusion and anterior lumbar interbody fusion. And then I want to talk now about some other mode of getting to the spine. And I'm going to be historical in that sense that I want to discuss some other approaches that were developed. So obviously ALIF we know about that since 1930s, PLIF 1950s, TLIF 1980s, and still the vast majority of our surgeries are done then. But then there is a so-called XLIF or LLIF, direct lateral interbody fusion, or XLIF for extreme lateral lumbar interbody fusion. What do you know about that? Did you learn them in your fellowship by
I was assisting my attendings for these approaches, not the DLIF, but the XLIF a few times, and it's a very it's position dependent. It's surgeon's comfort and the need of access surgeons occasionally. That's what I've seen. But it's again the surgeon's preference, and I believe for the XLIF you do have to go through the psoas muscle.
That's the definition of it.
It's exactly the definition, and so
psoas approach.
And you start to kind of, when you see the patients, you start also developing, a belief, patients complain mostly of hip weakness post-surgery, and I believe like with all these different approaches, there are different benefits and disadvantages, and XLIF is one of them. Okay.
Yeah, no, this is a typical position for, let me go back here. I want to show you a typical positioning for the direct laterals. Well, now I don't have that picture here right now, but practically you go in direct lateral, meaning you go directly from the side, and patient has to be positioned on the side because you go straight down. And obviously you make a small incision, maybe about 2 to 3 inch sometimes, so not that small on the side. You go through the abdominal muscle, then you go actually through the psoas muscle, which is this muscle right here, to access the spine. And actually this was described and was more popularized in 2000s with a company that called Nuvasive.
Correct.
And the problem is here, number one, you have to put the patient on the lateral side. When you do that, it becomes harder to put screws in that. Once we do what we call lumbar interbody fusion, usually we put screws in this structure here and here to stabilize the spine.
Procedure.
Yeah. And when your patient is on the side, that is become really difficult to do. So most of the people that do XLIF or LLIF, first they approach the disc, they take the bad disc out, put a spacer in, and then they break all the sterile field, turn the patient on the belly, and then put the screws in the back and internally brace everything. And that becomes a little tiresome because first you have to do one surgery, then take everything off, turn the patient on the belly, and then do a fusion from so practically you do 2 surgeries. Now,
correctly. Which is now the advent of the prone lateral position to try to eliminate the 2-stage surgery within the same day or even the 2 consecutive days.
Yeah, and this is a so-called the prone lateral, where you go from the side but your patient is still laying on the belly, it is a rather complex surgery. It's not a straightforward surgery at all because it requires us, you see the surgeon is sitting down, going from the side. It is a situation that most of surgeons are not used to in the spine, okay? Now, let's go back to our slide here. Now, this was developed in 2000, 2005, was gaining popularity, and is now actually losing popularity because, again, you have to do one surgery, break the crops and the sterile field, turn the patient, do another surgery. There's yet another surgery, we call that oblique lateral interbody fusion anterior to psoas. Or in the past as well has been called oblique anterior lumbar interbody fusion, where patient is on the side, that helps the organs to fall to one side, and you go to the spine, as the name says, anterior, meaning in the front of the psoas, anterior to psoas, meaning in the front of this muscle here. So you go to the spine in this angle right here.
Correct.
Did you get any experience in this procedure?
One time during an invasive cadaver course, and I thought that was the first time I saw the ATP approach, and I thought this is brilliant because with the XLIF and the prone lateral, you don't have the good access to L5S1 if you really want, and this one shows you exactly just you're in front of it.
No, and that is another thing that we need to talk about while we are talking about that. Obviously, PLIF you can do in most of the spine, though in upper lumbar spine and thoracic spine, you have to be extraordinarily cautious. You cannot push on the spinal cord. TLIF, practically, that is what the people who do TLIF are saying, that the reason they do TLIF because they can do it almost in any level. And there is not a really limitation on which level you can do that. ALIF is a beautiful surgery for L5S1, the very bottom of the spine. It is a good surgery in L4-5, meaning the second disc from below, but then becomes increasingly harder higher up you go.
Correct.
Now, because there are major vessels that you have to move around.
Correct.
That's how we discovered Adamkiewicz.
And the older you get also,
yeah,
we saw it often, calcification of the big vessels, the bifurcation allows to very hardly to manipulate and mobilize.
exactly. Now, XLIF, it's a very good surgery for L1, from bottom, third, fourth, and the fifth disc from below. It is practically, I know of nobody who does XLIF or the lateral approach for the L5S1 because your hip is in your way.
Okay. Or a separate incision, not through the same incision.
Well, the problem with the XLIF is just from the side, the hip is not going to let you go in. It's just not possible. It is practically a contraindication for L5S1. For L4-5, I did a handful of it, and most of the people I know, they did a XLIF on L4-5, meaning the second disc from below. They quit doing that. Do you know by any chance why?
Probably the difference in men and women in terms of the height of the iliac crest as well.
Yeah,
that
that
could
is
be.
one factor, the iliac crest, meaning the hip, your hip is still in your way. But as well, you see that muscle that you have to go through. By the time you get to L5S1, there are some major nerves go through this
Plexus.
muscle. We call that lumbosacral plexus.
Yes.
And those are spread out.
Yes.
Some studies have shown that you can have up to 35% risk of nerve damage, irritation problem if you do it in L4-5. And that sort of, I quit doing it after a handful of L4-5s, and most of the people I know, they don't try not to do that for L4-5 anymore. Because whereas in upper lumbar spine, you have one or two nerves going through this, in the L4-5, you have 5 nerves going through that. It's unlikely you don't get any of them. Because if you have to go through that,
Correct.
Obviously, you have to poke a hole in it. So, practically, XLIF is a good surgery for L1, 2, 2, 3, 3, 4, what means the third, fourth, and the fifth is from below. ALIF is a good surgery for first two bottom disc. OLIF ATP, you can go all the way up to L1, 2, but in the very bottom disc, it's very, very different surgery. It's not the same kind of surgery, and it's more complex. So, and you see, because almost none of this surgery let you do surgery on the entire spine, still most of people are still doing transforaminal lumbar interbody fusion or TLIF because it allows you to go to many places. But meanwhile, we haven't talked about the two procedures that I perform very often. The oblique lateral posterior lumbar interbody fusion, where we literally go through that small, tiny membrane. OLLIF stands for oblique lateral posterior lumbar interbody fusion, where we go through that thin membrane and we are, so to say, posterior to psoas and enter the disc still at the place that it's what we call in the retroperitoneal space, meaning that where the organs are not there, but avoid both muscles in the back and all the organs in the front. Now, and there is another variation of OLIF that we go a little even further lateral. It becomes our version of prone lateral. So, but in our version of prone lateral, we don't have this very complex setup in this way, and we are not sitting down, we are not doing all of that. It's all with the so-called, smaller incision and x-rays done. Now, let's actually talk about these different approaches because each of them has its own strengths and weaknesses. Now, I think the most important part of the strength of the PLIF and TLIF is that everybody learns it in their residency or fellowship. Everybody gets a lot of experience in that. And in medicine, everything is about experience. And having more experience, it doesn't matter if you have a better tool or a worse tool, like a pilot, it doesn't matter that this airplane is better. If you have experience with another airplane, flying with the other airplane, even though the airplane itself is not as good as the more advanced one, it's still safer for you because you have more experience. So the vast majority of the advantage of PLIF and TLIF is that almost everybody has experience with it, a lot of experience. We learn it in the residency. We are in a control environment. We do a lot of that. And that, believe it or not, in my opinion, is a huge advantage of it.
Correct.
Another advantage of PLIF and TLIF is that you can do it on many levels. But advantage of ALIF, let's talk about that, is that you can put a much bigger spacer in, and nothing compares to the cage or the inserter. When these days we don't put a piece of hip bone anymore. We put a piece of plastic or metal, we call it a cage or spacer, inside where the disc resides. And the size of that is the biggest with the ALIF, anterior lumbar interbody fusion. And I think that's a huge advantage because then there is less pressure on a smaller area on that spacer if the spacer itself is bigger.
And less blood loss, if you're talking about solely the advantages.
Yeah, these are the advantages. Now, advantage of OLIF or OLIF ATP is that you still put a big cage in it, and you can do it for other level that ALIF cannot do. At XLIF, as well, you put a big cage in. As a matter of fact, the cages in all the front part are all huge. They are the same size. And that is advantage for all of them. Now let's talk about disadvantage of each of the groups. I mean, otherwise, if PLIF was good, there was no reason to develop TLIF and have all these different things and so on. So do you want to start talking about the disadvantage of PLIF and TLIF?
Soft tissue stripping for number one,
Yeah.
nerve damage number two.
Oh, as a
And
matter of fact, I want to show you a few slides here, which I think is important. These are all the muscle in the spine. And we have to talk about some dirty secret of the spine surgery. The first dirty secret of spine surgery is that when we do surgery, we're stripping all this muscle and we don't reattach them. Like these are the spine muscle. And when we strip the muscle from the spine, we actually cut where these muscles are attached. And we just let them float in and we don't reattach them. What happens to them after we strip this muscle from the spine?
Fatty degeneration mostly.
They become scar. Yeah, they're not muscles anymore. The other disadvantages is that once we detach them from their origin, they cannot regulate themselves how much, like a muscle contracts, but there is a mechanism inside of the muscle that tells how much to contract and when to stop. By cutting the attachment to the bone, we are disrupting it. And for PLIF and TLIF, that is the main reason why it takes so long to recover from PLIF and TLIF, because you have to wait for those muscles to die before patient can regain function. You see, after the surgery, when the muscle is just floating, the muscle contracts, but it never gets a signal enough. So it goes to spasm. So this patient have tremendous difficulty to ambulate. And this is a patient few years after the surgery where I did a 2-level TLIF, and those muscles are all scarred. There's no muscle there. In comparison, in the different surgery that I did, and I didn't cut the muscle, that pink tissue is live muscle that still is very, very advantageous for the patient. Now, as well, the vascularization of the bone is through surrounding muscle. When you strip the muscle, you're reducing the vascularization of that bone to 25% of the original value. So that is a true disadvantage. And the last disadvantage I want to talk about is that when you literally kill these muscles, you don't just kill them in the level you do the surgery. You remember those muscles go many levels up and down? Now listen to that here now. This is L4-5-OLIF. Those muscles are gone. These are not muscles anymore. As a matter of fact, look at that. That is a muscle, how it's supposed to look like. This is scar. Now, this is 2 levels above it. The so-called muscle here, we call that multifidus muscle, still has turned into scar. So the effect of that is as well not just limited to the level you do the surgery. Many levels above and below, you still are reducing the effectiveness of the spine. So that is a disadvantage, I would say, from posterior fusion. Now, we talked tremendously about the disadvantage of so-called anterior lumbar interbody fusion. You want to talk about the risk profile of the ALIF?
The risk profile of the ALIF specifically, again, these are the major vasculature structures that are, the aorta, the vena cava, and also specifically for men, young men below 40, we advise them not to have that approach because of the retrograde ejaculation. And again, the other disadvantage we're talking about, less specific patient-related, is the access surgeon need for the approach. So major vasculature, the organs, bowels, perforation,
Okay,
higher
what I'm
mortality
going to
rate,
show you
really.
here now is a little about the anatomy of that area. Do you see how crowded that area is? Now, obviously, we have to maneuver around all those structures and push them away and so on. And most of the time, we can do that pretty good job doing that. Look at that, the nerves and so on. When we get there, that is when we go from anterior, you see there are no nerves there, but the last one, you see there are lots of vessels there. When there are not nerves, there are vessels. When there are vessels, and so on and so on. There's something always there, right?
Correct.
But let me show you, this is how they look like. These are structures that we have to maneuver around to get there. And this is a cadaver. In a real person, they're not color coded, right? You don't go there and their nerves are yellow and so on. This is what you see in a cadaver. Now, in a real person, it's all covered with blood and it is much more difficult. Now, that is the skill of a surgeon to maneuver around that area, go through all of that and not injure anything. But those risks are real. People still die of vascular injury through LIF and all the anterior approaches. And then we make lots of kind of new methods to overcome this. And those new methods is what we just talked about, the so-called OLIF ATP, XLIF, and the so-called the transcambin OLIF, the one that I am an expert on. So what is for the OLIF and XLIF, the major disadvantage is that you have to do it in a lateral position. And if you do it in a prone position, it is a very awkward, very difficult learning curve. It's still doable, but most of the people that I know are doing prone lateral, most of them, they abandoned it after, a good amount of number because it is an awkward surgery. And you remember, even though TLIF has a lots of shortcomings, if you are the best at doing TLIF, that's still the best surgery in your hand. Doesn't matter if the other surgeries have some other advantages. Now, the advantage of OLIF is that we don't have to go through the back, we don't have to go through the front, and it causes truly minimal amount of disruption to the surrounding tissue. But every surgery has as well its own disadvantages. The disadvantage of OLIF is the cage size. Cage size is the same size as TLIF. It's not as big as ALIF, OLIF ATP, and XLIF. And obviously, the learning curve for very bottom one, for the L5S1, is steeper because you have to, again, maneuver. You go under the pelvic structure and so on. And that is as well a disadvantage, the learning curve for L5S1. And now, talking about all these different kind of approaches, I actually want to show this slide here. So Dr. Gilmartin, do you want to show us and talk about what this slide shows us?
It shows the different approaches to the lumbar spine to have an interbody fusion done. What levels are actually amenable to do those fusions, and in what position is best done. In short, as an oversight. So for instance, let's say we're talking about ALIF, best levels to do those, to that surgery is between L4S1. We can do the surgery in lateral and prone, and it is mainly a muscle sparing procedure. And it can be done in an ASC, which is an ambulatory surgery center, if it's a skilled surgeon with a skilled access surgeon, but it's a narrow selection. In terms of
what does that mean? What does that mean, narrow selection? What do you understand under that?
I appreciate it. So meaning that the patients that come into the category of patients that is suitable to have this procedure done for this specific level, specific location, which is ambulatory surgery, is very small. You cannot translate it to a wide area of patients population.
Well, let's start with TLIF PLIF. It says generally it's not considered a surgery center case. Why not?
Correct. Because of the duration of the surgery, the muscle, the tissue damage, and the post-operative rehabilitation of the patient.
Ambulation just take them a long time to be able to
Get
reach.
up
And
because of
not
the anesthesia duration as well.
anesthesia duration is an extremely important fact. As a matter of fact, most of anesthesiologists are not going to let you do a surgery in a surgery center that takes more than 3 hours.
Correct.
Entire anesthesia time, because these patients are not going to be able to recover from anesthesia alone in a time that is suitable to send them home same day. So MIST-LIF, most of the time, if the surgeon is very experienced, they can do a 1 level, maybe 2 level even in a surgery center. But again, it comes back to that if you do a 2 level, it can be a longer surgery. And as well, you have to select the patient very, very carefully. Like
ASA 1 or 2, mainly, the morbidity level of the patient and the skills.
no, most of our audience may not understand what ASA.
Oh, so the morbidity status of the patient, how healthy the patient is, if the patient has multiple comorbidities, which means supporting post-operative and intraoperatively, like you
I
said,
mean, like bigger patient who have difficulty with,
obesity, diabetes,
and
yes.
so on. And so maybe you can do a young man with a BMI of 22, body mass index 22, young skinny guy. You can do a 1 level or 2 level max in a surgery center, but you are not going to do a difficult case in a surgery center. By the way, most of the surgeons still do regular TLIF. MIS TLIF is gaining way more popularity in the last few years. But even MIS TLIF, the problem is there that you
Learning
have to
curve.
repeat the same surgery. Like if you do a 1 level TLIF, regular TLIF versus 2 level TLIF, you're not doubling the time. But for the MIS TLIF, you have to repeat all the levels, especially when patients get bigger. MIS TLIF become technically very challenging, meaning you have to go deeper to do the surgery. Now, for the ALIF, OLIF ATP, and XLIF is more or less the same. There are good surgeries. Sometimes you can do 1 level. If you're a good surgeon, you have a good team, you can do it in a surgery center. But you have to select the patient very carefully. Now, why is it important even to do a surgery in a surgery center? Why is it even is that even a thing?
First of all, it's always appealing to, well, we know that in an ambulatory surgery center, the surgery is going to be less invasive and patients are able to go home the same day or the next day, which is always appealing.
It is less risk and is actually cheaper for the
Cheaper
healthcare,
financial, of course.
and outcomes are generally better. Like, some people say it's just a selection bias. Doesn't matter. The risk of infection in an ambulatory surgery center is 1/7 of a hospital. And if, God forbid, somebody get infected, those bugs are less dangerous bugs than in a surgery in a hospital. And as well, our society, we have been doing, according to Becker Spine, we are doing over 1.6 million spinal instrumented fusion. And those are so much more expensive to do it in a hospital. So our society, our healthcare will collapse if that trend just continues. So it's important to be more efficient and do those surgeries as a day surgery. Like there are lots of books on economical factors that they show if we would still do appendectomy or cholecystectomy or hernia repair in the hospital, all of those are being done in the surgery center these days. If we would still be doing them in the hospital, our healthcare system would collapse, completely collapse. Because we don't have that much money to pay for it anymore. In the past, we didn't used to do it very often, but now we do it very liberally. If we would, and as a matter of fact, an economic book I read was saying that if we would do a cholecystectomy, appendectomy, or hernia repair and keep the patient in the hospital 5 days, as we used to do it in 1970s, our economy, healthcare economy, would completely collapse.
In how many
That
days?
double number of the beds and so on, we couldn't afford it. You know why we couldn't afford it? Because people had to get paid, and paying for so many more people to take care of those patients in the hospital is extremely, extremely expensive. So it is a huge advantage to do any surgery that you can in a surgery center and send the patient home same day. Now, as you see here, there are only small selection of the surgeries that you can do in a surgery center. As a matter of fact, last time I checked, less than 3% of the lumbar spinal fusion surgeries are done in the ambulatory surgery center, less than 3%. That means 97% are still being done in the hospital. And I think that is what our approach, OLIF, can really change. Not only we have now 11 papers that shows the risk of the infection is less and so on. But as well, we can do it on a broad group of patients with higher BMI. I have done 3-level OLIF fusion in our surgery center on patients with BMI of 50, above 50, which would be even in a hospital a big deal with other methods. Now, but again, OLIF is a toolbar, is a tool in a toolbox that has as well, other tools. In that toolbox, there are as well other tools like, at least only in experienced hands, OLIF should be done for a grade 2 spondylolisthesis. Whereas everybody learns to do ALIF or TLIF for grade 2 spondylolisthesis, only you have to be very experienced to do OLIF for a grade 2 spondylolisthesis only in L5S1. Probably less than a dozen people in the United States are able to do that. So learning curve is a problem. And again, learning curve is always a part of anything. Now, I think another advantage of OLIF is that once you learn all the variation of it, you can go from mid-thoracic to from your chest spine to your pelvis and approach all the levels. So I think that is as well a very important thing that it's important there. Now, I'm going to put maybe 2 more slides here for us to review. But more or less, I wanted to, just finish it up here with these slides that shows all the development of different approaches. And do you have any additional, the comment or information you want to share, Dr. Gilmartin, with our audience?
Regarding this slide and the times.
Yeah, regarding these different approaches, these slides, or as a general. What when your family, when you gather with your family for Christmas or Eid, gathering, and they all want you to fix their spine, that is what family does.
Of course, that's what we all talk about at dinners.
Yeah.
Now, I understand what you're so like I said, because of my international background, I was able to do 3 fellowships, which was a requirement and a necessity, but it also allowed me to see different approaches, different ways of tackling the discogenic problems of the spine and getting into the fusion. And so I was familiar with the PLIF. I was then the second year, I was doing exclusively TLIFs, maximum invasive. And then the third year, I was seeing multiple like XLIFs and prone laterals. And as I was actually, and then I got to actually acquainted with Dr. Abbasi, and I visited him one time in his surgery and observed the surgery. So I had actually multiple methods of fusion surgery. And I remember when I knew that when my attending let me to do a 2-level TLIF, it took me and along with him 8 hours. And patient waking up not only with all the detriments of the prone positioning for such a long time, the anesthesia and a week in the ICU, suddenly we were able, or I was able to observe a 1 to 3, 4-level OLIF surgery in less than 2 hours, multiple levels, patient stays or goes home the same day. And for me, and that is what the topic was with my family dinners at AID. I said, I need to learn this new technique because this opens a door to provide my patients. Because at the end of the day, we're in healthcare, we're in a service providing care. And if we can provide the best way of helping patients with the same pathology, why not grab that opportunity? So this is my take on multiple approaches. Like you said, if there was a golden standard, we wouldn't have approached the spine 360 degrees. And I believe Olaf, to my knowledge, is, and you said it as well, you cannot, it's a tool. It should be part of the armamentarium of a spine surgeon. If there is multiple outer fusions, you cannot do the Olaf. But I think it's a very enriching and a very, very great tool to have as a spine surgeon if you want to offer your patients.
Well, thank you so much, Dr. Gilmartin. And now it was a really pleasure to have you on our podcast. I hope for most of our audience now that at least they have a good understanding of all these different methods to get to the spine. And obviously, you can get to our webpage, get to our YouTube channel. We have a lot more information we can share with you. But it is exactly 1 hour since we started our podcast.
True.
To stay
Time
with
management
the
is
time
perfect.
limit, to stay with the time limit, we are just going to wrap it up. Thank you for joining us. Thank you, Dr. Gilmartin.
Thank
I
you,
hope
Dr.
I see you
Abbasi.
soon here. And then everybody, thank you for joining our Essence of Medicine, different approaches to the spine, all the lifts you can have. Thank you for Essence. I'm Dr. Abbasi, and our guest is Dr. Gilmartin.
Thank you again for the invitation, Dr. Abbasi. Thank you so
Bye-bye.
much. Take care. Bye.